Hi guys, I'm live. I'm just going to share this link with everyone. Alright, so we're going to have a discussion on amenorrhea. Alright, so amenorrhea, I think I should just wait for some people to join. Alright, hi guys. I think I can see three people in the chat. I think I'm just going to start with amenorrhea. So basic, and also like, is the audio fine or should I use earphone? Can someone reply? Is the audio fine or should I use earphones? I'm assuming the audio is just fine. Okay, thank you. It's fine. So, amenorrhea basically means the absence of menstruation. Now, it can be physiologic or it can be pathologic. Physiologic is obviously when the woman is not in her reproductive years, so that is before puberty and after menopause. Even in her reproductive years, that is during pregnancy and lactation, there is amenorrhea. The reason for obviously pregnancy, amenorrhea during pregnancy is anovulation, and during lactation, it's because high levels of prolactin will inhibit all the gonadotropins. Now, when it comes to pathological amenorrhea, it can either be primary or secondary. So, the primary amenorrhea is when there is delaying of menarche, but so and the delaying can be constitutional as well. That is, there can be like a family history of late menstruation. So we have to have a particular age threshold in mind. So the age threshold is 14 years without secondary sexual characteristics, and 16 years in the present. So if there's a girl who comes to you at the age of 15 years, but she has secondary sexual characteristics well developed, then you would rather wait for another year until the age of 16 before you call it a case of primary amenorrhea. Now, suppose a case of primary amenorrhea comes to you, that is at the age of 14 without secondary sexual characteristics, or at the age of 16 with secondary sexual characteristics. You first see like how do you work the case out. So you start with seeing the secondary sexual characteristics. Now, if the secondary sexual characteristics are present, then what you do is you do an ultrasound, and with after the ultrasound you look for the presence or absence of a uterus. Now a uterus can be absent and that will be a congenital defect. So before we go to the various genetic reasons or the congenital reasons for amenorrhea, I'd like to touch upon the normal sexual development. So whenever you're talking about a sexual development, I'm only talking about the anomalies or the congenital defects causing amenorrhea. So we have some five defects, genetic defects, and that's what I'm going to talk about. So whenever you're talking about, say, sex differentiation, whenever fertilization takes place, the ovum will always contain the eggs, and the sperm will either contain the eggs or the Y. If the X is fertilizing, it will form a female. If the Y fertilizes, it will form a male. Now, whenever you're talking about sex differentiation, you talk about it at four levels. One is the genetic level. XX is a female, XY is a male. The second is the gonadal level. In a female, you will have the ovaries. In a male, you will have the testes. The next is internal and external genitalia. Now, by default, first of all, for the gonads, for the ovaries to develop, the two main criteria are you need two X chromosomes and the absence of a Y chromosome, which in turners you have only one X chromosome, and hence the ovaries don't develop completely. They are not functional. They are called streak ovaries. Now, for the testes to develop, what you need is the SRY gene, which is present on the short arm of the Y chromosome. The internal and external genitalia in any embryo by default will always be female. Now, in the female, again, how the internal genitalia develops is from the Mullerian duct or the Mullerian system. The internal genitalia include the fallopian tubes, the uterus, and the upper one third of the vagina. Now, the external genitalia develop from the cloaca, that is the vulva and the lower two thirds of the vagina, along with the urinary system, or the urinary bladder and the ureter. So, this is the by default female development of the internal and external genitalia. In the male, what happens is because there is a testis, the testis will contain the Sertoli cells and the Leydig cells. Now, the Sertoli cells, I guess you all will be able to see here. Is it straight or is it the other way? Yeah, it's the other way around. I've put a link of these notes in the description, the chart. In basically, the Sertoli cells are responsible for secreting Mullerian inhibiting factor, which will inhibit the development of female internal genital system from the Mullerian duct. And the Leydig cells from the in the testis, under the influence of HCG, human chorionic gonadotropin hormone, will secrete testosterone, which will inhibit which will promote the formation of the male internal genitalia, that is the epididymis, vas deferens, and seminal vesicles from the Wolffian duct, that is the mesonephric duct. And the paramesonephric ducts are the Mullerian ducts. And the testosterone will also promote the development of the male external genitalia from the cloaca itself. It will promote the masculinization of the cloaca. It will inhibit the female external genital organs from developing. And this testosterone will do by converting into the active form dihydrotestosterone, that is DHT, using the enzyme 5-alpha reductase. All right. So whenever again, so talking about a female and a male, whenever you talk about sex differentiation, there are four things we talk about. The genetics, that is XX is a female, XY is a male. Gonads, ovaries which develop because of 2X and absence of Y in a female. Testis which develops because of the SRY gene present on the short arm of the Y chromosome in a male. Internal organs by default in any embryo will be female, and they develop from the Mullerian ducts in a female, and in a male, if they will be the Mullerian duct to female will be inhibited by the Mullerian inhibiting factor, and the leading sex will secrete testosterone, which will promote the development of the male internal organs as well as the external organs via the dihydrotestosterone formation, and the external genital in the female and in the male. Now over here, in all of these steps, we can have 5 defects. The first is Turner syndrome, obviously, where instead of the XX in a female, you have an X0, you have a single X, because of which the development of ovaries does not take place properly and you have streak ovaries. However, the formation of internal and external genital organs in a female are not dependent on the gonads, that is the ovaries, in any way. Hence, internal and external genital organs will be developed. The uterus will be present, however, it might be infantile in some cases. However, also, since the ovaries are not present, there won't be enough estrogen, and hence secondary sexual characteristics will not be developed in a Turner syndrome patient. We've gone through some. We all know the basic signs and symptoms. The female comes with a short stature. There's absence of secondary sexual characteristics. She has a webbed short neck with cubitus valgus, shield chest, widely spaced nipples, and a short fourth metacarpals. She has streak ovaries with high FSH and LH because the FSH and LH don't have the ovaries to work on. And the uterus is present, but it might be infantile. So the treatment for Turner's is you give her hormone replacement therapy with conjugated equine estrogen 0.625 milligrams with progesterone. If she can get pregnant if you use IVF with donor eggs, and if she comes to you early, you can start giving her GH for getting a good height. The second congenital problem you can have is uh, the pure gonadal dysgenesis. That is, ovaries are absent in a female. Right now, this pure gonadal dysgenesis, again, internal and external the genital organs will be developed properly because the ovaries do not affect the development of the internal and external genital organs at all. However, again, since the ovaries are not functional, estrogen will be absent, and um, your secondary sexual characteristics will be absent. All right. Um, and in a male, if the same thing takes place, if gonadal dysgenesis takes place in a male, it's called Swyer syndrome. Now, this is also a condition of male pseudohermaphroditism. In a male, genetically, the male will be XY. And because there is a Y chromosome and there is a SRY gene on its short arm, the gonad will be the testis. However, the testis is degenerated, or it's not functioning properly. So the testis will not secrete your Mullerian inhibiting factor or testosterone. And hence, the female internal and external genital development will take place. It will not be inhibited by the testicular genes, by the testicular hormones. So what will happen is uh, your uh, internal and external genitalia will be a female. The testis will be redundant or dysgenetic, and secondary sexual characters. What happens is in the periphery there is conversion of androstenedione into estrogen. So there is breast development, and hence the appearance is completely that of a female. However, genetically the person is a male, hence you call it a male pseudohermaphroditism. Again, over here, eh, what happened? Your treatment. This condition basically is called Swyer syndrome. The treatment is cyclical estrogen progesterone, and the test is how it is redundant, but it carries a potential for malignancy. Hence, the testes have to be removed. Since the patient has internal genital organs like the uterus, IVF can be tried with donor eggs. Uh, the next part, congenital defect, is a Mullerian agenesis or MRKH syndrome. MRKH stands for Mayer R is Rokitansky-Kursner-Hosner syndrome, or Mullerian agenesis, where the Mullerian ducts from which the internal genital organs of the female develop, that is the uterus, fallopian tubes, and the upper one third of the vagina, they are absent. The Mullerian ducts have undergone agenesis. This is called MRKH syndrome. So now again, the ovaries are properly functional. Genetically, the female is an XX. It's a female. Ovaries, gonads are functional. Internal genital organs are absent. External genital organs, again, can be present. But obviously, the vagina is atreated. And the external genitalia will resemble that of a female because it is a female in all sense. She will also have secondary sexual characteristics but will present with amenorrhea because there is no uterus to share the endometrial lining. So what treatment you can give her is obviously there is no uterus, so conception is not an option. However, just before her marriage, to solve basically her sexual functions, you can have her a vaginoplasty done. There are two surgeries you can do for this. One is Mackendorf vaginoplasty, and the other is Williams vulvovaginoplasty, for which operation can be done. And the fifth one is again another case of male pseudohermaphroditism, where the testes are present. So it is a male genetically, it's an XY. Gonads are testes, so it's again a male. And the testes are functional, so they are producing Mullerian inhibiting factors and they are producing testosterone. However, the peripheral receptors for testosterone are defective, and this is called, anyways, I'll just talk about it more so it just becomes clearer. So since Mullerian inhibiting factor is being formed, it will inhibit the formation of female internal genital organs. It will form, all right. So you will have no uterus. That is one point. The second is the testosterone is being formed. but the testosterone receptors are not being formed, and testosterone conversion to dihydrotestosterone is not being formed. So your external genital organs will resemble that of a female again, because you don't have DHT and you don't have Mullerian inhibiting factor, and Mullerian inhibiting factor will be absent, so uterus formation will not take place. And uh, basically, this is known as testicular feminization syndrome, because although the testis is present and testosterone is being formed, it won't be able to act. Why it is called a feminization syndrome is because this testosterone is converted into estrogen peripherally, and this results in feminizing characteristics like breast development. And so then this is that's why this is called a testicular feminization syndrome. So again, in testicular feminization, which is also called androgen insensitivity syndrome, the testes are present, but the peripheral testosterone receptors are defective. So testosterone gets converted into estrogen, results in secondary sexual characteristics like developed breasts. The external genitalia resemble that of a female, but there is no uterus since there is no Mullerian inhibiting factor. Now, there's also something called as the partial androgen insensitivity syndrome, where half of the receptors are working and half of them are not, and which is also known as a Riefenstein syndrome, where you will have scanty pubic and axillary hair and ambiguous genitalia. The treatment again over here is vaginoplasty with gonadectomy, because again the testes hold malignant potential. There's no way they can conceive because there is no uterus, and they have to undergo if they want a child, they should, I think, go for, like, they should go for an adoption. There's no other reason. So we've discussed five genetic problems that might lead to amenorrhea. All of them might present at different stages, but this is just one thing that keeps confusing most of us. That's why I thought I should just discuss all of them together. But suppose a patient comes with you with primary amenorrhea, and the secondary sexual characteristics are normal, and you do an ultrasound and you find the uterus absent. In that case, you go for a genetic karyotype. Since the uterus is not there, we discussed five syndromes right now, out of which two of them there will be no uterus. So one is the if you get on genetic karyotyping, you get an XX. That means it's a female with no uterus. Then that means it's a Mullerian agenesis or an MRKH syndrome. If it's a male, you get an XY on a genetic karyotyping. That means it's an testicular feminization or an androgen insensitivity syndrome. So overall, what we need to remember is MRKH syndrome or Mullerian agenesis is the second most common cause, and the androgen insensitivity syndrome or the testicular feminization is the third most common cause of of primary amenorrhea. Coming to the other causes now, I think I'm just going to pause a little bit and see if you all are following. You all can maybe send in some comments. Am I going fine? I can see like four people. Can someone write if I'm going fine at a right pace? Okay. Okay, never mind. So now suppose the uterus is present. You do an ultrasound and you see that the uterus is present. That means there's either a problem with the outflow. That means the endometrium is being shed, but it cannot come out. Or there is a problem with the hormonal issues. So talking about the outflow, uh, you can have what is known as cryptomenorrhea. That is, there is a menstruation is taking place. Endometrium is being shed, but because the outflow tract, there is an obstruction in the outflow tract. It doesn't come out and it isn't apparent menstrual bleeding. So the reasons can be imperforate hymen, which is congenital, obviously. You can have a transverse vaginal septum, or you can have cervical stenosis, which can be acquired. This can be a cause of secondary amenorrhea more often. Cervical stenosis, which is acquired after some operations or disease. Now, imperforate hymen, what happens is what we are talking about is cryptomenorrhea or false amenorrhea. Now, in an imperforate hymen, basically the patient will come with cyclical pain and acute retention of urine because every time she menstruates, there is accumulation of blood in the vagina because it cannot come out because the hymen is not perforated. This is known as hematocolpos, accumulation of menstrual blood in the vagina. When it accumulates so much so that it reaches the level of the uterus, it's called hematometra. Again, there's still space. So if it keeps accumulating and the patient keeps neglecting the pain, it can reach the fallopian tubes. It can be called hematosalpinx. And if it reaches beyond that, leaves outside the ostia of the fallopian tubes, it reaches the peritoneal cavity. And this, it's not normal blood; it's actually endometrial lining, and hence endometrial lining present outside the uterus in the peritoneum or any other region. It's called endometriosis, and hence imperforate hymen is one of the risk factors for endometriosis. And on examination, you will see a tense bluish bulge from the hymen in place of the hymen, which is nothing but the blood accumulating. The treatment is simple. You give a simple X cruciate shaped incision. Uh, you give a surgery, and all the blood will come out. So that was imperforate hymen or cryptomenoria. Now, suppose the anatomy of the uterus is fine, the outflow tract is normal, then you check for the hormones. Hormones, the most important thing to remember here is the HPOU axis: hypothalamus, pituitary, ovaries, uterine axis. Right? So far, I think we have ruled out what are the uterine causes. Now, what we need to rule out are the HPO axis or the endocrine factors. So, and these endocrine factors are actually more often seen in secondary amenorrhea. They cause secondary amenorrhea more often. So I think we'll discuss about that a little later. Talking about primary amenorrhea, this was all when secondary sexual characteristics are present. But suppose secondary sexual characteristics are absent, you next look at the height of the patient, the stature. If the stature is short, we already discussed it's a case of Turner syndrome. Case of primary amenorrhea coming in the absence of secondary sexual characteristics and short stature. Turner syndrome, you do a genetic karyotypic, you will find an X0, which is, by the way, Turner syndrome is the most common cause of primary amenorrhea. So primary amenorrhea, most common cause Turner syndrome. Second most common cause is Mullerian agenesis or MRKH syndrome. Third most common cause is testicular feminization or androgen insensitivity syndrome. Now, if the stature is fine, it's normal, then you do an FSH and LH test. That is the endocrine test. Now, if the FSH and LH are high, then you do a genetic karyotyping again, basically because there seems to be a problem. If FSH and LH are high, it means their target organs, that is the ovaries or the gonads, have a problem. So you do the genetic karyotyping. And we've already discussed this. If it comes XX, and let's think, it's an XX genetically, the gonads are not working, but secondary sexual characteristics are absent. The stature is normal. It means it's a case of pure gonadal dysgenesis in a female. That is, the ovaries have undergone dysgenesis, they are not producing enough estrogen, hence secondary sexual characteristics are absent. Obviously, in this case, hormone replacement therapy will help. If the genetic karyotyping comes out as an XY, so let us think again, it's an XY, so it's supposed to be a male. The gonads are supposed to be testis, but and there are no secondary sexual characteristics. The stature is normal. It's coming with but the external internal genitalia obviously are that of a female. It's a Swyer syndrome case where the testes are not working and the uh, peripherally there is conversion of androstenedione to estrogen, and hence the breast development and sexual characteristics are present. That's why FSH and LH are going to be high. Suppose the FSH LH levels are low, then again the case causes can be congenital, like GnRH deficiency, hypothalamic causes, because FSH and LH are released in response to gonadotropin releasing hormone from the hypothalamus, right? So congenitally, if GnRH deficiency or if there's something known as Kallmann syndrome. Kallmann syndrome is again a hypothalamic defect where there is anosmia along with hypothalamic defect. So there can be infertility, amenorrhea, etc. Or it can be an acquired case of anorexia nervosa. Anorexia nervosa is basically when the body weight is not maintained as per the required age and height, and there's not enough body fat for menstruation to take place, and this is again a hypothalamic cause, where the patient needs psychotherapy and hormonal replacement therapy for treatment. Now, now that was short stature with FSH-LH high Turner syndrome. If it comes with a stature with FSH-LH low, then it can be an intracranial lesion or an empty sella syndrome. I've made a chart of this and I've put it in the link. I've put its link in the description box below, so y'all can go through. It will be easier to follow if y'all have that open simultaneously, or y'all can write as I'm saying, because I can't show this here. All right. Now we come back to just the whole table. A case of primary amenorrhea presenting with secondary sexual characteristics normally present. You look for the ultrasound, look for the uterus. Uterus is absent. Do genetic karyotyping. If the karyotype comes out of the XX, it's a Müllerian agenesis or MRKH syndrome. If it comes out of the XY, then it is testicular feminization or AIS, androgen insensitivity syndrome. If the uterus is present, you look for obstruction in the outflow or cryptomenorrhea. If there is no outflow defect, then you look for the hormonal excess. Now, this is where we had stopped in this chart so far. So we'll continue here. If the FSH is high with with normal secondary sexual characteristics, with everything normal, then we can have something known as the Savage syndrome or the gonadotropin resistant ovary, where the ovaries are resistant to gonadotropins like FSH and LH. So here, obviously, um this can be again a cause of secondary amenorrhea. The next is, if suppose the FSH and LH are low, that means the cause can either be in the pituitary. The problem can either be in the pituitary or it can be in the hypothalamus. All right. So hypothalamic causes can be something like psychogenic causes like anorexia, like we already discussed, or it can be pituitary causes like pituitarism, craniopharyngiomas, or adenomas. Adenoma, the most common pituitary adenoma, is a prolactinoma or right, where again you have high prolactin. Now, talking about high prolactin, this is something we're going to be discussing in secondary amenorrhea, but I think I'll just cover it here so we don't have to discuss it again. Whenever prolactin is basically hormone produced by the pituitary, uh, where the normal prolactin levels are around 25 nanograms per ml. Now, if it increases to about 100 nanograms per ml, you call it hyperprolactinemia. That is increased prolactin in the blood. And the causes can be many. There can be other endocrine disorders like thyroid problems, or you can the problem can be with drug intake, because dopamine is prolactin inhibiting hormone, and decreased dopamine will increase the prolactin. So all your drugs like antidepressants and all other drugs that will decrease dopamine will actually increase prolactin. Now, if the prolactin levels are more than 100, then it's what is known as a prolactinoma, that is a pituitary adenoma. Uh, and pituitary adenomas or prolactinomas can be micro or macro. So microadenomas are less than 1 centimeters in size. Macroadenomas are more than 1 centimeters in size. And well, what you do as a treatment is basically you look for the cause of prolactinemia, hyperprolactinemia, and you rule out the cause. You remove the cause. If it's a drug, then you stop the drug intake. And basically drugs that inhibit prolactin release, like bromocriptine or cabergoline or quinabolide, those drugs can be given. Um, so that was about hyperprolactinemia and prolactinoma. Uh, and the most important thing over here again, so is increased LH-FSH ratio or polycystic ovarian disease, PCOD. But this is actually a more common cause of secondary amenorrhea. So we're going to discuss that with secondary amenorrhea. I think I'm done with primary amenorrhea here, with all the causes and or the workup of a primary amenorrhea patient. Before we go to secondary amenorrhea, I would like to know if I'm going fine and if there's something that I should repeat or I should change. Okay. I think I'll just revise primary amenorrhea quickly. It's the absence of the onset of menstruation uh, in the absence of secondary sexual characteristics at 14 weeks, in the presence of secondary sexual characteristics at 16 weeks. Alright, you look for secondary sexual characteristics. If they are present, then you do an ultrasound, look for the uterus. If the uterus is absent, you do a genetic karyotyping. If it's an XX, it's a Mullerian agenesis. If it's an XY, it's androgen insensitivity syndrome or testicular feminization. If the uterus is present, you look for outflow obstruction or cryptomenorrhea. If the outflow is fine, you look for hormones. You do an FSH LH. FSH is high, most probably Savage syndrome or premature menopause. Premature menopause is obviously a secondary amenorrhea. That's why we'll cover it up later. If FSH and LH are low, the causes can be in the hypothalamus or the pituitary. PCOD we'll discuss with secondary amenorrhea. If the secondary sexual characteristics are absent, you look for the stature. The stature is low, most probably it's a Turner syndrome. The stature is also normal. You do an FSH LH again. FSH LH are high. There's a problem with the gonads. You do genetic karyotyping. If it's an XX, it's a pure gonadal dysgenesis. If it's an XY, it's a Swyer syndrome where it's a male pseudohermaphroditism case. If FSH and LH are low, then it can be a hypothalamic condition, which again can be congenital, like GnRH deficiency or a Kallmann syndrome. With Kallmann syndrome is anosmia with amenorrhea and infertility, or it can be an acquired hypothalamic condition like anorexia nervosa. This was the chart for primary amenorrhea. Now, secondary amenorrhea is defined as not getting you have had your menarche, but now you are not getting your periods for more than 6 months or three consecutive cycles in a row or consecutively. So the most common cause normally of secondary amenorrhea is pregnancy, but it's a physiologic cause. So the first thing you do when a secondary amenorrhea patient comes to you is a pregnancy test. You rule out pregnancy. The other common causes are hypothyroidism and prolactinemia, hyperprolactinemia. So you do a serum TSH, you do a serum prolactin, and you do a pregnancy test. These are the three things that you do at first, and rule out if these are the problems. Then obviously hormone replacement. If there's hypothyroidism, you give a thyroid or thyroxine, and if there's hyperprolactinemia, you treat with bromocriptine or cabergoline, and you treat the underlying cause of hyperprolactinemia. For prolactinomas, I forgot the treatment is again drugs that will decrease prolactin secretion. But if the adenoma is refractory to that, then you can either give a radiation therapy or you can go in for a surgery, which is known as a transsphenoidal adenectomy. So that was the treatment for prolactinoma. Uh, Now, suppose in a secondary amenorrhea case, the woman is not pregnant, her thyroxine levels are normal and her prolactin levels are normal. Then what you do is you give her a progesterone challenge test. That is, you give her progesterone for 5 days and you withdraw. Now, the main reason behind this is that normally menstruation occurs because of the withdrawal of progesterone from a estrogen primed uterus. All right. So when you are withdrawing progesterone, you expect menstruation to take place. If menstruation takes place after withdrawal, it means that when you're giving a progesterone challenge test, that is, you give progesterone for 5 days and you withdraw the progesterone, and menstruation takes place, then it's basically an anovulation case. It's a case of anovulation because anovulatory cycles were taking place and there was no progesterone withdrawal. The type of diagnosis made is usually the most common cause of anovulation in during the reproductive years is PCOD, and so the diagnosis made is PCOD. We'll be discussing about PCOD in much detail later. However, if no bleeding takes place even on progesterone withdrawal, then you go on for the next test, which is known as the estrogen plus progesterone test, E plus E test, where you give estrogen for 21 days, that you prime the uterus with estrogen, and then you give progesterone for the last 10 days, and then you withdraw the progesterone. Now, if the bleeding takes place then, it means that estrogen wasn't enough earlier. And if there is no bleeding yet, it means that when you've corrected the error with estrogen, you've corrected the error with progesterone. No bleeding is still taking place. It means there's a problem on the target organ itself. That is, there's a problem with the uterus. And this problem is usually what is known as the Asherman syndrome, where there is actually adhesion of the anterior and posterior walls of the uterus. So what happens is in the uterus when there is an overzealous dilatation and curettage or due to any disease like tuberculosis, there is an injury to the stratum basal layer of the uterus. What happens is the adhesion of the anterior and the posterior walls take place of the uterus, and this leads to secondary amenorrhea and infertility. So what you do is for an investigation over here is a hysterosalpingography. What you see on an HSG is a honeycomb appearance. The gold standard for diagnosis, however, is hysteroscopy, and the treatment is hysteroscopic adhesive lysis. So using a hysteroscopy, you lyse all the adhesions or the synechiae between the uterine walls. You insert a copper T so that the anterior and the posterior walls don't come back together to prevent the readhesion, and then you supplement using estrogen and progesterone as a treatment for Asherman syndrome. So this was a problem in the main problem in the uterus, because of which there was no bleeding even on giving estrogen and progesterone. Now, suppose bleeding did actually take place after giving estrogen and progesterone. It means initially the problem was in estrogen secretion. That is, the problem was in the ovaries. Then, to detect if the problem is in the ovaries or if it is on a level higher in the pituitary or the hypothalamus, what you do is an FSH and LH. If the FSH and LH levels are less than 5, it means the FSH level is less than normal. It means the problem is in the pituitary. The pituitary is not stimulating the ovaries enough, and hence the problem is at a level above the ovaries. You look for problems in the hypothalamus and the pituitary. If the FSH-LH levels are more than 40, it means the ovaries are problematic and the pituitary is trying hard to stimulate the ovaries to cause ovulation. And hence the FSH levels are more than 40 international units per liter. That means there's ovarian failure, right? So for ovarian failure, again, most common cause is obviously PCOD. There can be something known as premature ovarian failure. Now, premature ovarian failure is when you get menopause before the age of 40 years. That is, the ovarian follicles diminish before the age of 40 years. Clinically, how you diagnose it is there is an absence of 3 consecutive periods for more than before the age of 40 years, or there is amenorrhea before secondary amenorrhea before the age of 40 years, and FSH levels are more than 40. Another other causes of ovarian failure, which can lead to secondary amenorrhea, are oophoritis, any infection or inflammation of the ovaries, or the Savage syndrome that we discussed about already, where the ovaries are resistant to the FSH being secreted by the pituitary. Now, if the serum FSH level is less than 5, it means there's a problem with either the pituitary or the hypothalamus. In the hypothalamus, if you look at it, the causes can be either stress, again, eating disorders like anorexia nervosa, hypothyroidism, or other endocrine disorders, or excessive exercise like in athletes. Now, in the pituitary, the most important hormone that plays a role over here is prolactin. Now, prolactin can either be high, which we already discussed, hyperprolactinemia and prolactinoma or a pituitary adenoma. We've already discussed the management also. Or you can have something what is known as the Sheehan syndrome, where there can be a loss of prolactin. Now, the Sheehan syndrome and the Simon's disease are basically 2 diseases that take place postpartum. What happens is because of postpartum hemorrhage, there's necrosis of the anterior pituitary. The posterior pituitary is protected from necrosis because it receives more blood supply during pregnancy, and hence during childbirth, when there is a compromise on the blood supply to the pituitary, the anterior pituitary is more susceptible to necrosis. Now, when 75% of the anterior pituitary is necrosed, it leads to something known as the Sheehan syndrome. If it's more severe and almost 95%, I'm sorry, I think I said it right. I don't know. I'll just repeat. 75% necrosed is Sheehan. If it's necrosed to 95%, it causes what's known as the Simon's disease. The clinical manifestations are very similar in both. Firstly, there's absence of lactation after childbirth because there is no prolactin, and prolactin is required for lactation to occur. And after that, there is amenorrhea. So the treatment over here is lifelong estrogen, thyroxine, and cortisol because anterior pituitary is releasing ACTH, it's releasing TSH, it's releasing FSH, LH, all hormones, and anterior pituitary is basically necrosed now. So this was the Sheehan syndrome and the Simon's disease. So we're done with the hypothalamic and the pituitary causes for secondary amenorrhea. And the most important, we're done with some of the ovarian failure causes. I just repeat the ovarian failure causes. You can have PCOD, which we're going to discuss next. We can have a premature ovarian failure or a premature menopause. We can have oophoritis, and we can have Savage syndrome. These were the ovarian causes. So before we start the PCOD, I'd like to ask if you all have any suggestions or questions, or if I should repeat some part. Is it? Am I audible though? I can see 5 people. Um, okay, great. So I think I should continue with PCOS. It's also known as Steen-Leventhal syndrome. It's polycystic ovarian disease. It's a benign disease of the ovaries where you have multiple cysts. The name is quite self-explanatory. Now, what is given in shorts is only the Rotterdam classification, so I'm only going to go through that. It's called the Rotterdam 2003 criteria for the diagnosis of PCOD, where they have given 3 criteria, out of which 2 should be fulfilled. The 3 criteria they've given is oligo or anovulation, that is absence or very little ovulation. The second is hyperandrogenism, that is masculinization or virilism features. Either biochemically you have increased levels of testosterone, or clinically where you have conditions like hirsutism. And the other is the third criteria is 12 or more than 12 follicles in the ovaries within one or both ovaries or USG with a volume of, or the ovary itself should be more than 10 ml in volume. So, what is important to know over here is that the FSH-LH level or the obesity, although they are increased risk factors and they do contribute significantly towards PCOD, they don't actually necessarily are helpful in diagnosing the condition as PCOD. And on USG, what you see are the cysts are arranged peripherally in the ovaries. So what you call it is a pearl or a necklace appearance or an arrangement. Um, Now, what is the pathophysiology of PCOS? Is that around the ovum in the ovaries, you have what is known as the theca cells of the theca granulosa. There is a hypertrophy, so it's called hyperthecosis. So, because of this hypertrophy, initially they release testosterone. This testosterone is nothing but a precursor towards estrogen, right? But however, and this process of conversion of testosterone to estrogen is called aromatization. However, this aromatization is defective in the ovaries itself, but not defective in the peripheries. So, in the peripheries, you have normal estrogen, but in the ovaries itself, the estrogen is lacking. Because of which, what happens is, or in the periphery, because you have high amounts of estrogen, FSH is suppressed by a negative feedback mechanism, and anovulation takes place. So, there is no ovulation, and there is again no estrogen in the ovaries itself. Now, what they have hypothesized is that insulin like growth factor and insulin itself will cause theca cell hypertrophy and eventually lead to PCOD. And hence, one of the most important treatments is metformin, which increases uh, basically decreases the resistance to insulin, decreases insulin itself in the blood by decreasing its resistance in the cells. The second most important part is the testosterone peripherally gets converted into estrogen um, by in the fat cells peripherally. So if there's obesity and a lot of fat cells, then obviously there's going to be more aromatization, This in turn it contributes to theca cell hypertrophy again. So um, uh, or weight loss basically that is also one of the important treatments for PCOD. So the investigations you do over here is FSH, LH. You do a glucose tolerance test to rule out diabetes and insulin insensitivity or resistance. There can be a lot of complications for this, like metabolic syndrome, diabetes, ovarian cancer, or infertility. Ovarian cancer, because any situation, I don't know why they've given ovarian cancer, but okay. Now, the treatment is obviously diet, exercise. You lose your weight, at least 10% of the body weight. You sensitize the body to insulin. So, insulin sensitizers like metformin and myoinositol. And you give because there's anovulation, there are irregular menstrual cycles. So, to regularize the menstrual cycles, you give OCPs and cyclical progesterone. One of the treatments, one of the most important clinical features of this is hirsutism. So obviously you treat a hirsutism using cyprotrone acetate containing OCPs, and you can also use finasteride or androgen receptor blockers, etc. So that was about PCOD. There are a lot of hormonal changes that take place in the PCOD. Let me just read what are the hormones that increase in PCOD. The most important thing over here is to know that the LH FSH ratio is more than 3:1. The reason for this is that the peripheral E1, the estrogen type 1, which is increasing the peripheral aromatization of testosterone to E1, it gives a positive feedback to LH, and hence LH levels increase. However, this same E1 is going to give a negative feedback to FSH, and hence FSH levels decrease, and LH FSH ratio is more than 3:1. The FSH decrease in turn obviously leads to anovulation, so anovulatory cycle. Uh, so I think I'll just go through the secondary amenorrhea workup again quickly. The most common cause of secondary amenorrhea is pregnancy. So any patient coming with secondary amenorrhea, irrespective of age, you do a urine pregnancy test and a sonography to rule out uh, pregnancy. After that, you do TSH and prolactin levels, because other common causes are uh, hypothyroidism and prolactinemia, hyperprolactinemia. Now, also the most common pathological cause of secondary amenorrhea is PCOD and tuberculosis. Now, once you've ruled out pregnancy, once we've ruled out hypothyroidism and hyperprolactinemia, we start with the progesterone challenge test to see if the cycles are ovulatory or anovulatory. That is, or basically that's the first step you do. And if there is a bleeding after giving progesterone immediately, it means there were anovulatory cycles. There was no withdrawal of progesterone that is needed for menstruation to take place, and hence we suspect ovarian failure or PCOD. If still no bleeding occurs even after giving progesterone, you give estrogen progesterone challenge test, where you give estrogen for 21 days, progesterone for the last 10 days, and you withdraw progesterone. If it again there's no bleeding, then it means there's a problem with the target organ or the uterus itself, and you suspect Asherman syndrome. If if there is bleeding, it means there was estrogen deficiency. Now to see whether the problem is with the ovaries secreting the estrogen or with the stimulation of the ovaries by the pituitary, you check the FSH levels. If FSH levels are high, that means there is a problem with the ovaries, and hence the pituitary is trying hard to stimulate the ovaries. And again, the ovarian problems, one of the most important ovarian problems is PCOD. The other problems are your Savage syndrome, premature ovarian failure, or you can have oophorytis because of infections or inflammations. If it's less than 5 international units per liter, the FSH level, it means there's a problem with the pituitary or the hypothalamus, because the ovaries are not being stimulated enough to cause ovulation. Now, now what are the pituitary? The normal causes are you count your prolactin levels. If prolactin levels are high, but within 100 nanograms per ml, then you suspect hyperprolactinemia. If they are more than 100, you suspect a prolactinoma or a pituitary adenoma. If they are less then you suspect, and the patient has recently delivered, then you suspect Sheehan syndrome or Simon's disease. For hypothalamic causes, you check for stress, eating disorders, other endocrine disorders, or if the patient is undergoing an excessive exercise. So these are all the causes and the workup of a secondary amenorrhea patient. I think we are done here. Primary amenorrhea and secondary amenorrhea both. If there's something you all want me to revise or repeat, um, I think the highlight over here, the most important part, at least for me to understand, was for the congenital defects, because it's not really given very well in any of the books. So I've shared the chart in the description box below. I don't know if you all can tell me if you all can access it. If there's nothing, then I think I should stop. I'm almost done. If there's something you would like me to discuss or revise again, let me know. Tell me how it was. Uh, all right. If y'all like something like this, then let me know if y'all are interested in discussing a topic like this. Really help me in preparing this topic. It's quite a vast topic, and yeah, and tomorrow Vaishnavi, my friend, is going online again at the same time. She's going to be discussing cataract from ophthalm. So do join in for that. I'll be sharing the link. Uh, I'm, I think I'm done with amenorrhea, and I hope you all have actually understand this discussion was of some help. If you all find any mistakes, then let me know. I've referred to Shaw's textbook, uh, Bhatia notes, which Dr. Ramyasri made us write. And for secondary amenorrhea, the chart given in Sakshi Arora is pretty good. So that's the chart that I referred to. There they have divided into compartments. So compartment one is the uterus, and compartment 2 is your ovaries, compartment 3 is uh, your pituitary, compartment 4 is the hypothalamus. So the def, then they've divided it all the problems accordingly. All right, maybe let me know what topics you all want next, and yeah, that's it. All the best, good luck, stay happy. Thank you.